No, we requested 63, but at the last meeting, we talked about the fact that they had recommended 59.6. And so it didn't change. It's still at the same level that the mayor recommended. We have had, we've had some discussions with other council people about other ways they could assist the hospital by getting us additional capital and even money from the 4% fund to support repair and maintenance of this old building, which would really actually help because I'm budgeting repairs and expenses. So if the city is willing to help fund some of those expenses, that will reduce some of our expenses in the budgeted year. It's not a commitment, but that definitely is an interest on behalf of several council people. So
Bruce, I have a quick question before you move on to that. With regard to those capital improvements,
yes,
is the only way to obtain those through, an infusion of funds through the city? Has there been any case where we were able to receive those through a foundation or some type of public-private partnership? Okay. So let's say we have XYZ Foundation we're able to make a great case for, and they are willing to meet the city halfway. Has there ever been that conversation?
I don't know that we've ever shared anything between the foundation and the city, but the foundation has purchased small equipment for the hospital that would have been capital in the past, but not a 50-50 or participation from Metro, but I think that's certainly a possibility.
Or another foundation, an exterior foundation. Yeah. So I'm just curious, as maybe we have this conversation offline, but I thought about this and had a conversation about this over maybe the last week, which is all of us know many people in the city. A lot of them are healthcare related. And if there is an opportunity to bring exterior resources in that we don't have to rely on the city for, right, but might be able to bring in as a foundation, another 501c3, who would like to bring in some resources, let's explore that. Let's ask. We have a lot of contacts in this city. And even if we could create a space where there would be matching dollars or some type of commitment at Metro's level too, corporate level, like let's really start thinking outside of the box. So what I don't want to do is just go and bang on Mayor O'Connell's door and say we need $20 million and please give me $20 million, right? Is there a way to do this creatively? So it's just something that came up in a conversation. I'd love to have a deeper dive with this with the right people. Thank you.
Sure.
Mr. Lesser has been interested in this and talking about it ever since he started here. And I think that, the Hospital Foundation, as we know it today, their budget isn't big enough to really help us in major capital. Am I right about that? Or
no, they really don't budget any portion of capital, but they have made major contributions through the foundation. In other ways, the van, for instance, right. The cancer, which is a very nice van. I think it's about $70,000-$80,000. Cooling units for our food pharmacy. Worked with AmeriGroup. So there have been a number of contributions. Team Chad works constantly with our foundation. To your point, it's just a matter of expanding that. It's already in place, and we have Ms. Baylog, who is our Chief Development Officer, who is in that role of leading the foundation. So it should not be a heavy lift to just expand that conversation to other would-be donors.
In other public hospitals I've been, it's oftentimes a foundation can identify a need. It's something that is heartstring towards someone out there, whether it's something for your oncology unit or something for the women's services floors. Those are easy to raise money for a particular piece of equipment, to go out there and make a request. And it's worked in other places. I think we've done it on a small scale here. It's just been a few years since we've really spent a lot of time and effort, but now we have a director full-time for development, and it's kind of time to get that moving.
I would add that that's one of the things that we'd like to rely on our board for is using your sphere of influence to help to identify some of those in advocacy capacity that even if it would be restricted resources to certain projects, that's fine, as long as it's associated with our mission.
Just thinking about taking it to the next level, new hospital, is there any chance Oracle, Amazon, moving to town, think that this is important enough to give, $20 million or something? Is that
Feasible?
been approached, or is it?
It's something that's come up. It is, I can tell you, it is on the radar of our Chief Development Officer. So I won't get too much into that, but to answer your question, yes.
I just feel like it's a real opportunity as our city continues to grow. I know that having friends of mine in the mayor's office over the years that have been in charge of, specifically from multiple mayors, the development and economic development piece, it's the expectation of any of these new companies that come in. Like, you will participate in our city. Welcome to Nashville. We don't have a lot of taxes. And by the way, how are you going to participate in philanthropy? And I love that about Nashville. And I feel like we could probably take that a step further, especially with our mission that is very unique and different. And I'd love to see our folks here, if it's a foundational drive, like you said, Dr. Webb, to lean in and to start to partner. And I will commit to being more than happy to help and be thoughtful about those relationships. Thanks.
Anyway, for the budget, there are minor updates. There's a little bit, we've had conversations with the state that we do feel comfortable that we are going to get the $1.1 million in GME funds that evaded us in last year. We had received it in 2023, did not receive it in 24, but we've been in conversation with both Meharry and the state, and they pretty much assured us that we should be able to pick back up that roughly $1.1 million. So that was added back into the budget for 25. And that's that, and then the updating of some of the revenues that we will generate from our Metro Center, because that was only up really for 2 months before we completed this budget. And they are generating just in professional fees about $1.3 million a year. So rolling that out to the full year with a little bit of growth. And then our imaging center was only budgeted for about $130,000 because we weren't sure exactly when it was going to launch. Now it looks like it will be in place early fall or late summer. And so we were able to add some dollars in those and effectively cash balance the budget for 2025. You can see it projects a small operating loss of about $320,000 operating margin for the year. But that's what we are. I mean, we're not allowed to accumulate cash. So our goal is to use the cash that we have for best services and then end up the year with a zero balance, basically. And that's the way the city likes it too. So I think the budget hasn't changed much from what you saw in the original, and the expenses are pretty much unchanged, just slight changes in the growth in some new areas, and then that 1.1 million of GME, that basically balances the budget. It would have been an easier haul. We're not making any reductions here. It would have been a little easier because we do think that we provide more than $59.6 million of service to the community for the uninsured, but that's what we're going to work with for 2025, and we think, Dr. Webb and I and the team, we think we can make it work. So that does need approval because it is a slight change from what you saw 2 months ago.
How much net are we making at this point off Metro Center? Because you mentioned 1.3 in revenue. What's our?
No, that's
That is
collectible.
our net,
That's
our
collectible.
Okay.
Yes.
And you said imaging was 130,000?
I'm sorry?
Imaging was 130?
We only had 130,000 budgeted because we actually had it budgeted to happen in the year we're in, 24, but it got delayed with the construction. So having it for a full year, we think that we're going to do well in excess of 130,000 net revenue. Mark's laughing in the background because he thinks he's going to do that in a quarter or something, which is possible. Yeah, it certainly could be.
I'll have you on record for that.
Yeah.
He's on record for that. Just
Well, Bordeaux, the imaging center is at Bordeaux. That's the net. But the clinic itself, to me, is not net new at this point because I don't have an additional provider out there. I'm just telling you, if I move a provider from here or from Charlotte over to Bordeaux, even though it's in a different location, it's not net new revenue to the hospital. Now, when we get another provider at that point, but I can't project that until I know that we have them. So, but yeah, Bordeaux, we have a fine physician out there 5 days a week now, and several of us attend to him, but I know we're trying to get another physician to join him. And when we do, that'll be net new, but it's not budgeted as net new because we'll have the expense of that physician.
I have a question real quickly, if you
Sure.
can discuss contract labor. I mean, as a percentage of both salary as well as a total expenses, it looks to be between 23%. Can you discuss that? I know we've talked about contract labor with regard to nurses, but what other major contracts are out there, and is that number going to change?
We're not projecting it to change substantially. I do think that we're doing a lot better recruiting new, particularly in nursing and ancillary areas. We're doing better. I think most hospitals, I don't know, Mark, you want to come up?
Currently, Mr. Chair, we're having 2 employee orientations a month now because we are having more than 20 new hires per session. So like today we had new members orientation. The week after the 4th, we'll have another one, and then at the end of the month, we'll have another one. So we're wanting that number to decrease over time. So there was like 6, 7 nurses in this morning's class.
Yeah. Nursing is probably about 60% of that spend, but it's actually steady or down slightly. I think that, when we have directors, we've had some directors that left service here, and we've been having to backfill them with contract. We just hired, I think, Krista, you met our new compliance officer. So when you're backfilling those key positions and you have to bring in those are fairly expensive resources to borrow on a 90 or 120 or 180 day basis. And that's what driving the other side of sort of the contract labor there. That does not include like physicians. That's under physician service. That's a different area. So whatever we pay for radiology or the emergency room coverage, that's actually not in contract labor.
And so how is that different than contract services, which seems to be approximately the same amount?
Contract services are a variety of things, typically not physician related. IT, think about things of that nature. Okay. IT or maintenance contracts or items of that sort. So they're contracts that we've entered into that we're committed to. I know Mark's going to bring us a few contracts later, and those fall into contract services. Okay. Yeah.
I just wanted to clarify. I know that there's lots of ancillary third-party entities.
Contract
we deal
labor
with,
is we're replacing a person who would have worked here in the hospital in a role, not a provider and not somebody who strictly does support. Like we have IT support from Presidio or others that do network monitoring and keep our network adequate. But if we lost them, we don't have a position for those people, and Melanie would have to hire 3 or 4 people in order to cover that. So that's not considered contract labor. That's considered contract service. I know it's a fine distinction, but that's the way we categorize them.
And you see that continuing? I just want to level set. So that sounds like it's both contract labor and contract services are about a 20% spend.
Yeah, contract labor, just to give you
Is that normal for, I guess, I don't know.
Before COVID, we spent about $3 million a year in contract labor.
Really?
3. And we've gone to 10, 11, 12, 13. And a lot of it is just a change, and all the hospitals are experiencing it. A lot of nurses left the industry, and a lot of nurses learned that you could travel, even if you're just traveling across town, and make $70 an hour instead of $35 an hour. And so unfortunately, Vanderbilt, Ascension, ourselves, we're all kind of trapped in that that contract labor pool. Now, more and more, we have nurses that are saying they want benefits.
Right.
They've got families, and so they made a lot of money for a while, but they're coming back to us. And we are recruiting pretty well. The challenge is keeping them. And I do think when we have Cerner operational, we're going to be more comparable to our peers than we are currently with a pretty manual EHR that our staff has to work with. We're at a disadvantage there.
Mark, how do we, I mean, when you first said you're having 2 orientation sessions, I thought that sounded like a good thing.
It is. It is a good thing.
But, you know, how many unfilled positions do we have as compared to a year or 2 ago, and as compared to before we had a contract with the recruiting firm that we have now?
So I'm going to speak specifically for ambulatory, and I know Veronica's reduced her, because at one point we were up like inpatient, we had like 78 nurses or something.
Okay.
Veronica was able to get that down into the low 60s and recruited staff. For ambulatory, we don't have, I think when I left to the conference last week, we had exhausted all of our contract labor that was in the clinic or ambulatory division. So we didn't have any nurse contract labor or anything like that. So that's what my comment came from, is my own internal divisions. I know that we've reduced that contract labor. For respiratory, I think Sharon has maybe 1 or 2 positions left. We've hired respiratory therapists, which was a part of that nursing pool that could travel and make a lot of money without being attached to an organization. But most of those people are actually looking for homes to have benefits like Bruce identified. So we've reduced that contract labor. At one point, we were up to like 11 to 12 respiratory therapists. Almost our entire department, with the exception of the director, was travelers. So we've been able to reduce that down to like 1 or 2 travelers in that department as well. So that's what I was speaking to about contract labor as far as ancillary departments in our ambulatory division.
Okay. But for hospital nurses, it sounds like we're filling the positions
Timing.
better.
There she is. So we were just talking about contract labor, and I was explaining to Dr. Martin how we were able to do that. Here you go, Veronica.
You can use that one, Veronica. Over there.
Oh, okay.
There you go, girl. Right there behind you.
Oh, okay. I'll just sit down.
Yes, it is, Dr. Brown.
So for nursing, with the human contract, we've hired 83 RNs. Originally, at the height of our contract labor, I was about at 78. I'm at 54. Right now, I'm at low single digits in all areas except for ICU and women's services. And that is a nationwide kind of trend that's going on. ICU is usually a pretty lucrative area, but they've been able to capitalize on their salaries across the nation. But we're working on it.
But you're filling the positions
Yes, sir.
better than you were.
Absolutely.
A year,
Well,
2
the
years
travel
ago.
market for RNs is actually slowing down at this point. And as Mark said, sorry, I was finishing up a meeting. As Mark said, has kind of shifted. And so you're finding more RNs that are wanting stability now. You know, traveling was attractive when I could make $100 an hour. Well, the rates are going down for RN positions. And so we've been able to actually convert some of our travelers here. That's how we were actually able to reduce that number. And of course, we're having to do sign-on bonuses for women's and ICU because that is just a spot that even our recruiters are telling us is a challenge. And it's not just a challenge for us, it's a challenge everywhere currently right now.
Are you pleased with the recruiting company?
I am, but I'm very interactive with them. I meet with them weekly. I hold my leaders accountable for their interviews and things of that nature. And we discuss if somebody's not timely, because I can't lose a candidate because you're not timely. So I think it's my relationship with human that has made that successful for me.
Good, thank you.
Thank you.
I'll just say I would love for us to only run $10 million of contract labor because I'd probably save us, it'd save us $1 million too, probably, and we'd be profitable for a little while.
Yeah. No, I was just curious if you saw a trend and then how that parlayed into other, like organizations. Is that something we're seeing overall? Which it sounds like I've heard before, but I was just curious if we saw something changing for that. Excuse me. Anything else?
Any more questions?
Okay. On that, it looks like I will need an approval to move forward with the fiscal year end 2025 budget.
Please.
So moved. I will second it. Any discussion? All in favor? Aye. Motion passes. All right. Next up, back to you, Mr. Naramore, for financial statements.
All right. April was a good month for the hospital. Pretty busy. 225 admissions for the month, so actually a little bit above the budget. Observation admissions, a little bit above budget as well. Our patient days were about 11% short of budget, but that was just because of good length of stay management in the hospital with our team and our providers. Let's see, emergency room volume was actually down a little bit in April. We had just instituted our no-wait ED in April. It's starting to have some impact, I think. May and June you'll hear soon, but it was still a light month in the emergency department in terms of visits, but it still produced 14 more admissions through the ER than we actually had budgeted, so it was a pretty good month in that regard. Our clinic visits were particularly high this month, over 4,200 clinic visits. Budget was 3,500, but of course we had not budgeted for the Metro Center to be part of the hospital in the original budget, and they do see 800 to 900 internal medicine patients per month in that location, so that certainly contributed to why we beat that number. Surgeries, inpatient cases were up pretty substantial. They doubled from the prior month, slightly above budget this month, and our outpatient cases were also above budget for the month. Cath lab was right on its number for April, and deliveries came up a little bit this month, but still well below the budget and trending kind of negatively for the hospital the last several months. Case mix in the hospital was down at about 1.37. That's discharge admissions, not necessarily Fanny's still in the hospital at this time. So that's it for sort of the stat page at the hospital level. And then on the income statement for the hospital, you can just see gross revenues for the total hospital were $24.8 million gross revenue, about a miss of about $800,000 on inpatient and $600,000 on the outpatient side. Net revenue, though, at $5.01 million was pretty close to the budget, about $160,000 shy. We had a good percentage at 20.2%, better than the budgeted net revenue percentage. Good payer mix. I'll give Dr. Blackledge's team a lot of credit for moving cash acceleration to the forefront and just doing a good job with getting things processed through. The Change Healthcare thing is finally pulsing through our revenue cycle system, and we're starting to catch those back up. And so you'll see good cash collection. The month we're in right now, I know we've probably hit 5.5 million.
5, 6.
Yeah. In 20, and I don't know we've ever had a $6 million month, but this might be this one, right? So excellent cash collection month, right? So it was a good, I just say, we're collecting as we go. This is a net revenue number, not a collection number, and it's an algorithm that we use to estimate our net collectibles. Our other revenues continue to be well above budget for the year to date and for this month in particular. And so we had about a $2.4 million favorable variance in net revenue. Some of that is those new clinics, but it's also some of the state dollars that we received this year. Salary or expenses, similarly about 1.4 million higher than budgeted. Salaries with the new clinic, et cetera, are about 12% higher than budget. Contract labor is still biting at 1.3 million. That's why it's hard for me to say we're going to drop that number. I still haven't seen it sort of drop significantly yet. I know we're bringing people in, but they've got to get oriented and in place, and then we can release some of that contract labor. So that's what we're working on. Supply expense is pretty high this month, and most of that is sort of our setup for Bordeaux, that obviously we have to outfit those areas, the imaging and the Bordeaux clinic, and then the fact that we've started using the robot, and case costs are a little bit higher with the robot than there are traditional surgical methods, but it's patient experience, and we think it's a net positive for the hospital. We'll open up a lot of other doors. Most of our other expenses were in line for the month, but with that 2.4 million favorable in net and only a 1.4 million negative variance on the expenses, we still had a small margin of about 240,000. We were budgeted to lose $750,000, and if you just look year to date, that we have a positive operating margin in the hospital of over $5.5 million. And last year at the same time, we had a negative $8.2 million. So it's been a pretty good run through the first 10 months of the hospital year.
I mean, we're 10 months now. Looks like for the fiscal year, we're going to be better off by at least $10 million.
Pretty significantly, yeah.
Is that unusual? Has that happened in recent years?
Here,
Yeah.
we've had good years, but probably we've never had a year this good, consistently solid. But some of it is outside revenue, that there's DISH money and other monies coming to public hospitals and in support of charity care and DISH. And I don't know how Ascension has fared with that, but it has definitely helped us because we have a high uninsured charity debt load. So the fact that the state is finally acknowledging some of that, and so we're getting higher payments under DISH than we had in prior years.
So I'm
That's
just
helped.
wondering if these outside revenue sources, is this a one-time thing for this year, or is it something we can expect
There
going
there
forward?
was $5 million. So I don't know if you look back, but if you look, we have about $5 million of one-time money that we received this year that won't be there next year, right? So that's why I can't project that we're going to do $5 million next year on the same run rate, because I know those were one-time monies. Now, that's politics. So I don't know that the state might not be pushed to do something again, but all we know right now is a lot of that was old ARP money and money that was being paid out because of the extreme costs, rising costs in health care. So the Medicaid programs were paying out one-time funds based on how much Medicaid business you did as a hospital. So, if Vanderbilt doesn't do Medicaid, they probably didn't get a lot of that money, but I suspect some of the Ascension hospitals did. Any place that does significant charity or Medicaid would have benefited from that, because our costs for 2 years were rising so fast because of contract labor and nursing costs, but Medicaid and Medicare weren't changing what they were reimbursing us. So there was acknowledgement at the federal level that they needed to do something to help pay that without changing the rates. So that's what happened, is they were paying money for charity and DISH payments at a much higher rate than in the past. But they've warned us all that that was one-time money and that we couldn't necessarily count on it going forward. Not just Nashville General, any hospital that's receiving those funds. So in the budget for next year, we're projecting a $5 million drop because of that one-time money. I'm projecting everything else to be steady, but that there will be a drop in that one-time money that we can't count on. Does that help, Dr. Martin?
Yes, thank you.
But we're doing well on our own also. I think last year we did about 53 million collections, and this year when we did the update, it went from about 54.5 to 57.2, and I know that's probably conservative considering what we're doing in June. And that's why we feel like we can hit that 61, 62 million number next year with our clinics and our imaging center and, just new focus in the hospital on growing our volumes.
I don't think you would attribute the entire look at the variance to just state funding. If you look at the net operating compared to year-to-date, you see a $5 million variance, even in the net operating on your document that you're looking at now.
Right.
So a portion of that is attributed to the work that's being done.
Yep.
Right.
Agreed.
Anything else,
Questions?
Dr. Martin? Okay, financial statements for, the cycle will need approval. Do I hear approval for April 2024 financial results? Second, any discussion? All in favor? Aye. Motion passes. Revenue cycle, Dr. Blackledge.
Thank you, Chair. Appreciate that. I want to back up and start where Bruce finished and left off. I just want to say revenue cycle is our responsibility to take all the activities from across the continuum of care areas, translate that and produce the cash. But I will say that I've watched a shift within the hospital for all the care teams, the administrative teams, everyone involved, to kind of collectively get together. And what you are seeing is the outcome of the entire team. So I have a few people in the room. I think I saw Faith over there. I always want to give a shout out to those individuals. I see Mark Chase, he's back in collections, and I see Yasmin over there in the corner. Raise your hand, she kind of hides out, she's HIM. But here, and the work that they do is extremely important. So when we look at the graph here ahead of us, if we take the 10-month average from July of 2023 across April of 2024, that's a 10-month period. And what we have is $4.5 million on average. When we look at that over the last 4 months, beginning in January 2024, just trending out the calendar year, you're at about 4.8 million on average. So when we talk about that cash acceleration, is 300,000 on average per month. Just kind of want to point that out. And when we think about May and June, even though we're not there, we're talking about April. May we were at 5.3 million and June at 5.6. So I want to point that out because that's given the trajectory and how that continues upward and forward. And that's a result of really inking out all of the operational efficiencies. So what are our people doing? How are they doing it? How can we change? How can we make it better? What can we do to get better? If we go to the next slide, I really just quickly want to talk about the unbilled accounts. In comparison to April 2024, we're down 0.87 of a day from the prior month of March. And as you guys remember, in February, at the end of February, we had the cyber attack issues. And so that bled over through the month of March, cash performance, all of the activities performance for March and again in April. We can go to the next one. And then lastly, from a denials management standpoint, we had a slight uptick of about $50,000. It doesn't mean that we will not get paid that cash. It's just a slight minor delay. We had some outpatient claims, smaller dollars, that for some reason the authorization didn't pass over from one system to the next system. But because the team has collectively, they get together regularly with good cadence and have good conversation, they were proactive in kind of understanding what the issues were and working to get those resolved. So we anticipate payment. They may already be paid, as a matter of fact. So looking forward, for us, it's all around probably three things I would say. One, how do we grow the business and continue what we have in play and make sure everything is working well and drive further improvement. Second would be the Cerner piece. How do we move to a readiness state to make sure our competencies are in place for all of our staff? We're ready to dispatch people to other areas within the hospital to make sure we have all our charges, input, and crossing over. And then thirdly, I would probably say is how do we enhance our digital tools for our workforce engagement, make life easier for our staff, and then so that we enhance our patient experience so that our patients get the benefit and the best care that we can provide for all of those coming to us. That's it for me. Any questions? Thoughts? Practice management insight. You say practice management was your new job, right? Yeah. Open to all of the above.
It's good. Thank you for the report. And we look forward to continue to see this trend up, and I know under your leadership it will. Next on the agenda is our contracts. So, Dr. Brown, first contract.
Yes, first contract, Acre. This is a contract that we had previously with another company that didn't live up to their obligation. So they had to go find a new opportunity. And so this is the second bidder. When we did the bid the first time, this was the runner-up contract. So we reverted to this contract, and so we're seeking board approval. This is for things to make sure that we don't have body parts out in the landfill, that we're doing the things that we were supposed to be doing as far as proper disposal of chemicals and stuff within the hospital environment. So this contract replaces that contract. The reason it had to come to the board, because again, it was a 3-year contract and it had a slight increase in the cost. Happy to answer the question.
How long did we have the previous company?
8 months.
Really?
Yes. So after about the 6th month, we decided they actually had someone here on site. It started out great. They had someone here on site, but then that person left, and then they wanted to hire a PhD to come on site, which would increase the cost of the contract. And then we said, no, thanks. We just need someone to lead us into how we properly dispose of things and give classes and stuff. But then they could never come back and provide anyone for that for those services. So we had to end that contract.
So did we have were we able to not keep paying them?
Yes, we stopped paying them. It went to our in-house legal. So we sent out a letter and everything to that company to make sure that they were aware of it, that we stopped paying them because we wasn't getting the services.
Were there any consequences to them not fulfilling their duties or us not being happy with their service model?
No, it was just a matter of making sure that we weren't doing things that we shouldn't be doing and making sure we were properly disposing of chemicals and stuff in the right manner. So they had a program together. It's just that they could never provide us with a person back after they lost the other person.
And is the cost of this contract comparable, similar
Yes.
to what we?
Yes, it was just a slight bump. It wasn't much of an increase to that between the two.
Was it also a 3-year contract?
Yes, it was.
And how many original bidders were there?
There were 3 original bidders. The one that we let go, this one was the second person, and then we had a third one. So there were 3 bids.
So, these companies, did we have references from other
Yes.
clients?
Yes.
And they were,
Right. They
Okay
just
with
ran
the
into
first one, but-
right. They just ran into a situation where we're not really large enough for them to place a PhD level person here, and so therefore they had a hard time backfilling that position itself. Now they may do well with other organizations, like a lot larger organization, because they probably need that level of expertise at those organizations. But what we were looking for, it wasn't what the RFP went out for, wasn't necessary what they were trying to do.
okay. Move approval.
All right. The Archer Inc. contract's been moved for approval, a second, and any discussion? If not, all in favor? Aye. Motion passes. Back to you, Dr. Brown.
Garda World Security. This is a existing contract that we have with Garda World. What we're doing is actually asking for more hours from that contract. Currently, the CNO, Ms. Elders, and I met with our security team, and the thing that we're having is that there's no way of securing the facility after hours. So this person would be needed to be posted at the visitor elevator. So after hours, what was happening, people would just come in and they buzz them in, they go upstairs. We don't know where they're at. By placing this security there helps secure the building at night to ensure that we have a process in place that these visitors go to the floor that they say they're going to go to, and that our staff is secure, and knowing that these patients are not just wandering the building and going wherever they feel like. So that's why we're asking for an extension of hours for this contract.
So we didn't originally budget for that? And,
No.
And it's been a problem?
So this is how the problem was identified. When we did the no-wait ED, that was identified by the Miss Elder's nursing staff, because they weren't accustomed to people just being buzzed in. The people that we had at the front desk prior to that would just buzz people up. So it was a problem. We just didn't realize it wasn't brought to our attention until that nursing staff was sitting at the front desk and wanted to know, how did they know that that patient was going to the 4th floor, or how did they know that that patient really had a relative in the hospital? So questions started being asked. And so Ms. Elders got with me, we talked to security, and we come up with a process for that. And one of the processes that we come up with was having a security at the front desk that would give a badge that would make sure the patient got on the elevator that went up to the floor that they were supposed, and then there's a back check to make sure that that patient made it to the floor. So that's how we come up. And so we need that person after hours, 365 days a year, and that's how we come up with the hours that we needed.
Just curious, how do you confirm that the patient went to the floor?
They can call up to the receptionist on the floor to make sure that the patient arrived.
And the elevator lights.
Lights on, right,
See where they're going.
right.
Does that prohibit them in any way from going to another floor?
Not necessarily.
Is there technology by which, as an example, I've been to other office buildings and they badge you for that specific
We
floor.
could-
So even if I tried to touch another floor and get off,
Can I
is
say
there?
this too?
Of
So
course,
in the
of course.
elevator, there are cameras, so like, you can see if you are that main security officer that's looking at the visual, you can see that person in the elevator and what floor they got off of. You can also see them, because there's not that many people traveling around at night, so you can also see somebody getting on the elevator, and are they going to a different floor? So I think we do have that capability. I don't think we have been intimately involved in that, but I wave at them sometimes when I'm in the elevator, because they can see what you're doing in the visitor elevators. So they can see what floor they got off of, they can see who's coming on. It'd be different if we were just like a really large facility where we had a lot of movement at night. We don't. And so I think that is just something that we have to hardwire with our security team moving forward.
Right. And we just want to make sure that the staff is safe after hours, right? Because in some areas, there's limited staffing. So take like imaging, for example, there's 2 technologists between 6:30 or 7 o'clock at night until 7 a.m. the next morning. And if one is in with a patient and the other one is sitting around and we all know that things happen coincidentally. It's not people planning to do something, but it just happens that way. So that's why we want to make sure that the staff is secure and the patients are secure at night.
And I guess risk is higher than it has been in previous years.
Yes.
Just out of curiosity, is it armed or unarmed?
This would be an unarmed guard. And the reason we chose a guard was because we want someone in uniform that would be a deterrent if we had the incident with people being rowdy and things weren't going the way they should. If they met a guard, it would be better than just an individual in plain clothes.
Is there an armed person?
Yes, we have
Here,
armed guards here.
24/7?
Yes, we have a team, and this person would be part of that team, Guard a World.
Yeah.
Are they all one unit?
Yes,
So they all work for this
Yes.
company?
yes.
Gotcha. And we've been satisfied overall with the performance throughout the hospital?
Yes. Ms. Elder's shaking her head, because they're normally the ones that we get the temperature from. Yeah, the ED nurses.
Have they been consistent, the people that they assign or they?
Yes.
Okay. Good. Okay. Move approval.
All right, so it's been moved that we accept the Gar Award Security proposal and contract. I would second that motion. Is there any discussion? Seeing none, all in favor? Aye, motion passes. Thank you. Back to you.
RPA. This is a physicist company that we've been using for years. I know we've used them for the last 10 years I've been here. We're wanting to actually go into a 3-year contract with them where we could pay them quarterly. I think before we've been paying them for bill services as they come in. So our radiology director would like to move this to a quarterly payment. We did send it out to bid, and they were the only companies that could go to quarterly payment instead of monthly payment. So this is required by the state for like when you're doing cath labs, radiology equipment. They do our lead apron testing and all the stuff that's required by the state and Joint Commission.
And why is it important to have quarterly payment instead of monthly?
It was a lot easier to make those payments at a quarterly based on, so that way they would be bundled together opposed to paying them individually when they do a service. They sort of get lost. So we want to just bundle those. That way we can make that one-time payment and then move on. And then any services that we need during those quarter payments, we could get those services taken care of a lot faster.
I would just say we've been pretty much on time and material, traditional. And so when they came in and did stuff, but now we've got multiple sites with imaging.
Right.
And so it's kind of changed the game. We're just trying to regular, I like to know what the expense is going to be all the time.
I didn't want to say that, Bruce, but
I do.
It's quarterly. It's
So
easier for
rather
Bruce
than
to
get
pay.
a $10,000 invoice one month and a $4,000 one the next month, this way it regulates the payment and the coverage. And they do have multiple sites. We added the imaging location out at Bordeaux.
Exactly.
And it's a significant imaging center. So now we're kind of in the big time and we need to step up.
Move approval.
Hey, one quick question. Is there anything that since we don't have any other bids because other people don't bill this way, it seems like an anomaly. Is there anything we're not going to be getting by going to a quarterly and going with this company comparative to maybe having 5 other options if we were fine with monthly? Is there an extra cost? Is there a better, what's the takeaway here?
So this company has been here with us since I've been here 10 years, and they've covered all of our needs. They cover our nuclear medicine. They make sure our isotopes are stored correctly. So they've done everything. So we're not going to miss anything, and then you're not going to get a lower price. This really contract is more for us than it is for them. That way we have an agreement where we will only have to pay them once a quarter. So it's not an increase in cost or anything like that, or we're not going to get a better deal in town by going with someone else. And then on top of it, we know these guys, they've assigned, we have one physicist that come to us to meet our needs. So it's not a change, or we're not going to miss anything. There's not going to be any gaps or anything like that.
This is a new contract we're starting for 3 years then?
Yes.
Is that correct?
Yes.
And the last time we went out to bid, it sounds like there was probably more than one person bidding because of the monthly pay. Is that right?
Well, when we first did it, like Bruce was saying, we were just paying for time and materials. So we didn't really have a contract per se with anybody. Okay. We just used them exclusively for our imaging services or for our radiation protection services.
Okay. Okay, it's been moved that we accept the Radiological Physics Associates contract. And I would second that motion. Is there any discussion? Not, all in favor? Aye, motion passes. Anything else? If not, I will move to adjourn for the Finance Committee meeting. Thank you so much.